and if you could turn your onto mute while we're doing presentations. Okay. Thank you. It's a pleasure to see so many of you here who've faced the torrential rain outside, and thank you for making the journey, and welcome to those of you who are online. As usual, we are relying on technology quite a lot for this conference, so please forgive us if there are any hiccups, and the presentations will be available both online and in person here and in the breakout rooms, so there's plenty of scope for things to go wrong. We have about 70 people registered to turn up here today, so welcome to you, and we have a further 200 registered to join us online. For those of you who are physically present, please note where the fire escapes are on the side of the building, and the loos are here at the back of the room behind me. If there is a fire alarm, we all gather in the car park opposite the International Pavilion over there. The conference is being broadcast and will be recorded, so I hope no one is objecting to this. If there is any objections, could you let Anna know? So, as I've asked before, if you could turn your cameras and on your microphones off while the presentations are on. If you can turn your mobile phones onto silent, and for once I've managed to do that with mine, I have checked as well. There is a ability to ask questions of the presenters. Obviously, for those in the room, try and catch my eye. And for those online, please put your questions in the chat box and we'll try to get as many of them asked as possible. When you ask a question, it would help us if you could introduce and say who you are. So everyone is here in this pavilion for the plenary speakers, and then we break out for the breakout sessions into this room and the two rooms over in the International Pavilion, which is just over there by the car park. It's pretty obvious, you just keep left of the shepherd and his sheep. For those of you who are joining on remotely, please click on the link to either room 1 or room 2, depending on which of the breakout sessions you wish to attend. Once your breakout sessions are finished, for those online, please click back on the conference link to join us here in the main room. And for those of you who physically walked over there, please physically walk back. As you will see, there is a fantastic array of posters, and there is a couple of things to note. A, that they're on the front and back of the setup over there, so don't miss the ones on the other side. And also they are numbered, and some of them have duplicate numbers because the posters have been done bilingually, so don't get confused about that. We have simultaneous translation in the room, so if we could just check that. So if everybody who's going to need simultaneous translation could take a set of headphones off the table and put them in your ears, and the translator will just say good morning to see that they're working. Great. Anybody with any problems with that, just let us know and we'll sort it out later. So I think that is the end of the boring housekeeping details. So I'll try not to bore you too much with my opening remarks now. As many of you will know, this is our 6th conference, and over the past 5 years, we've heard about solutions that people have developed to rural problems like access and lack of local resources. We've heard about innovations to solve rurality and sparsity of population. Solutions such as remote diagnostics, different training methods. We've heard from inspiring individuals who broadened their area of practice to cope with the demands of a rural population. We've heard from pioneering groups who've maximised the social capital in their area. These are just a few of the themes we've explored. Now, it seems to me that these issues would be applicable to the NHS across the UK. After the triple whammy of COVID, Brexit, and the Ukraine war, it seems that the solutions we've been trying to find to our problems are now problems that are encountered across the care sector. People are short of staff. People are wondering how they can maintain and enhance the social groups that have set up during COVID to improve the well-being of their populations. We are wondering how we can quality assure different innovative solutions that involve social prescribing and green prescribing. We have been looking at solutions to all these problems for many years here, and now I think these are going to be applicable to a much wider audience than just a rural audience. As they say, necessity is the mother of invention, and we've been driven by these necessities for many years, and I think now other people are appreciating those necessities. So next year, maybe we shouldn't just call it the Rural Health and Care Conference. Maybe it should just be the Health and Care Conference. Anyway, I think I shall stop there. And we have been honoured with the Minister wishing to open our conference yet again. So assuming the technology is working, as she's not actually in the room, we will have the Minister opening our conference. I'm reliably informed it's fine because it's a pre-recorded message. So Anna, if you could put Eleni on the screen, that would be great.
Bore da, dwi'n diolchgar iawn am gael dod yn ôl I agor y gynhadledd iechyd a gofal gwledig eleni eto. A dwi eisiau croesawu pob un yma heddiw, a mae wirioneddol yn ddrwg gennau na allai fod yna gyda chi. You'll all know that recent years have been difficult as the global pandemic has continued to impact everyone, albeit now at a more manageable rate due to the success of the vaccination programme. Of course, COVID-19 is still with us, and we must continue to keep ourselves safe as our health and care services work towards recovery. We're now heading into winter, which is always a challenge, and this winter is anticipated to be even more challenging given the current economic environment. We're seeing increasing costs, which will inevitably impact on our NHS in Wales, but also on us all personally too. But despite these huge challenges, I continue to be hugely impressed with our health, social care, and our third sector workforce, who continue to deliver vital support to the people they serve. The dedication and commitment that you demonstrate in delivering for our citizens is really admirable. It makes me really proud to be the Minister for Health and Social Services here in Wales. The workforce is and will always be key to delivery. Through the Strategic Review of Education, Health, Education and Improvement Wales, they have ensured the continuance of health professional education in rural settings. For example, by establishing a new nursing programme in Aberystwyth, through dispersed nursing contracts specifically for residents living within Powys and Hywel Dda, and through the new contracts, Wrexham Glyndŵr University are establishing an academic hub in St Asaph. This helps to further embed health professional education across more rural parts of Wales. With this infrastructure in place, it assists HEIW in phase 2 of the strategic review to engage widely about developing further post-registration opportunities across Wales to meet the needs of the whole population. There'll be a specific focus on learning and development opportunities for staff working in rural areas, with the training focused on the specific needs of rural communities. We will continue to increase staffing numbers through a range of retention and recruitment strategies, including international recruitment, where there is ethical, and we will make sure that it is ethical, and we will continue to fund record investment in our education and training programs. We're also developing a workplace implementation plan that will underpin the workforce strategy for health and social care, with a series of short and medium-term actions to address immediate priorities in our workforce, ensuring we have a sustainable workforce fit now and for the future. The health and social care landscape has changed dramatically over recent years, and healthcare provision has developed to improve the delivery of care to patients. Further changes will require a workforce prepared to respond effectively and flexibly to evolving models of service and care delivery. A Healthier Wales, as our long-term plan for health and social care, encourages organisations to find new ways of working together. It focuses on a broad multidisciplinary team approach where well-trained people work effectively together and all the up-to-date and relevant information about the individual circumstances and preferences is shared. Now, this ensures we make the best possible use of everyone's skills and experience. The development of a new independent medical school in North Wales will enable us to train more medical students here in Wales. And this will ensure that we distribute both training opportunities and the provision of well-qualified doctors across Wales. In addition, a collaborative approach between Welsh Government, Cardiff, Swansea and Bangor universities has been adopted to deliver the increase in medical education opportunities in North Wales. This will result in students having the option of spending a far greater period of their studies in North and in Mid Wales, undertake significant elements of their studies in community-based and rural settings, and develop the skills and ethos required to work as part of a multi-professional, multidisciplinary team. This programme is an important step in Wales towards enabling students to have more choice about where they study medicine and a chance for them to experience care being provided in rural and community-based settings. Overall, I hope this will have a positive effect on the recruitment and retention of doctors across Wales, which will in turn allow patients the opportunity to receive care as close to their home as possible. The way in which we work together across the system is more important than ever. And of course, providing services in our rural communities can present particular challenges and opportunities, and is something we must continue to deliver. One way of taking action to improve both our mental well-being and physical health, as well as embodying the preventative approach we're taking here in Wales, is through social prescribing. Through social prescribing, we can have more choice, more control, better health. Social prescribing empowers people to connect with their own communities, to access support which will improve their health and well-being. Social prescribing is a key priority for the Welsh Government, and work is underway to take forward the programme for government commitment to introduce a national framework for social prescribing. We want to develop a person-centred model of social prescribing in Wales, and a national framework that embeds a whole system approach to accessing prevention services and well-being activities across all referral pathways. We've recently consulted on the national framework in order to agree a Welsh model of social prescribing and to develop a common understanding of the language used in Wales. Identify also what actions can be taken on a once for Wales basis and understand the technology needed to embed the model across Wales. We've received an excellent response. My officials are currently reviewing the responses with a view to publishing the final framework next year. As we're all aware, digital technologies have played a critical and a very successful role in our response to COVID-19 and continue to be a part of delivering health and social care in Wales. This is enabled by applying lessons learned, by engaging with and listening to users, patients, carers and citizens in developing digital technologies for health and social care services closer to home. And this should mean that people can remain independent, comfortable and safe in their own homes for longer. We continue to invest in addressing digital inclusion and in improving digital literacy to support those who wish to gain the confidence and digital skills to participate in this digital world, as well as providing alternative ways to access health and care services in Wales, which will be as good as those offered online. A major benefit of remote working and video consultations within rural communities is the time and the money saved with not needing to travel. The number of video consultations has meant that patients have saved 58 minutes travel time per appointment, equating to 317,000 patient hours saved. 31% of clinicians working from home and 85% prevention of face-to-face consultations, leading to 9.5 million miles saved for patients and 1.69 million kilograms of carbon dioxide equivalent saved. Welsh Government is continuing to work with the NHS to provide, in a more inclusive way, additional digital tools for clinicians and patients to make processes as efficient as possible. This includes a longer-term plan for how we embed video consultations into the technology available to GPs and other clinicians as a standard offering, allowing clinicians to spend more time with patients. A key focus is to establish a technology-enabled care centre of excellence on an all-Wales basis that provides a hub of knowledge, expertise, and a one-stop shop for all providers of telecare, telehealth, and video consultation services across Wales as a key enabler and support for our communities. Healthcare provision also has a key role to play in reducing CO2 emissions, and we must embed our response to the climate agenda in a way that we plan and we deliver our services. And Aaron Bevan once said, "We know what happens to people who stay in the middle of the road. They get run down." And so in Wales, we're taking bold action, and the Cynhadledd was the first parliament in the world to declare a climate emergency. We have ambitious plans for all sectors to be net zero by 2050, and for the public sector to lead the way and be net zero by 2030. All NHS organisations are fully engaged with the decarbonisation agenda and have developed their own decarbonisation action plans to drive forward delivery of the NHS Wales Decarbonisation Strategic Delivery Plan. We've continued to develop the way primary and community care services are delivered through an accelerated programme, bringing together services into pan-cluster planning groups. This has supported integration of services, which enables the right care to be provided at the best place for the patient. For instance, pharmacies play a vital role in our communities in every part of Wales. Prescription Newydd, the new pharmacy contract introduced in April, has extended the range of clinical services all pharmacies can provide, reducing demand on GPs and supporting access to treatment without the need to wait for an appointment. Our future approach for optometry services policy, published in 2021, set out our plans for eye care over the next decade. This led to the agreement of a new optometry contract in September. It will improve access to eye health services in the community and in hospital eye departments by enabling patients to access eye care services delivered by the right professional in the right place, first time, across the entire care pathway for primary care optometry and specialist hospital eye care services. The delivery of integrated health and social care services is important, and in April, I was delighted to announce the launch of a new and ambitious £144 million Health and Social Care Regional Integration Fund. Our aim is that by the end of the 5-year programme, we will have established and mainstreamed at least 6 new national models of integrated care, so that the people of Wales, wherever they live, can be assured of an effective and seamless service experience in relation to community-based care, emotional health and well-being services, supporting families to stay together safely and therapeutic support for care-experienced children, home from hospital services, and finally, accommodation-based solutions. In this first year, the Welsh Government officials are working with regional partnership boards on developing a set of robust plans which take into consideration the bespoke needs and challenges of the people living in each of the regions, such as rural communities. This approach ensures we create a strong foundation for the next 5 years, whilst considering where some enhancement or acceleration of those plans may provide additional capacity and resilience even this winter. Diolch eto am y gwahoddiad I agor y gynhadledd heddiw a gobeithio byddwch chi yn mwynhau. Thanks again for inviting me to open today's event, and I do hope that you enjoy the conference.
Thank you very much, Minister, for your words, which covered many of the themes that we'll be covering during this conference. And as someone who's been involved with rural services for many years, I think it's encouraging to hear that our argument that patient journeys were as important as clinician journeys for accessing health has been given extra emphasis by the climate crisis. I think that helps us with that argument. It's now time to move on to the first plenary session. And have we got Steve Moore online?
I'm here, Jack. I'm here.
Hooray. Morning, Steve.
Good morning. Good to see you.
I shall hand over to Steve, who is the Chief Exec of Hywel Health Board. We have the 3 health boards who cover the area of Mid Wales, which was where we were started, and they are going to talk to us about how they've learned from the last few difficult years and some plans for how we might progress in the future. So, Steve, thank you. Over to you.
Thank you, Jack, and it's lovely to be here today. I'm hoping my Wi-Fi lasts out for everybody. As I say, I am delighted to be here today, and apologies that I'm only here virtually. I think the use of technology to such a great degree has been one of the hallmarks probably of the pandemic. And it does sort of mean that you can almost be in 2 places at once. And today, for me, unfortunately, is one of those days. But I hope next year I might be able to be there physically at the conference. The title of today's plenary, Learning from the Past and Looking to the Future, I think comes at a time when doing so has probably never been more important. Everything that we've been through over the last 3 remarkable, unprecedented years has provided probably far more lessons than the whole preceding decade. Indeed, I think I've learned more about being a chief executive in those 3 years than in my previous 10. We've learned so much in this period that probably in 15 minutes, I'm only going to be able to scratch the surface. So I'm going to attempt to summarize probably 3 broad lessons I've learned and kind of what that might mean for the future. So my first lesson, the NHS, despite many rumours to the contrary, can move at amazing speed when faced with a single national imperative. Our teams did remarkable things in the early days of the pandemic, establishing fully equipped field hospitals in a matter of weeks. There were 9 just in Hywel. We also reconfigured every acute hospital in Wales over the same timescales to divide our front doors into red and green areas. And as the pandemic evolved, and of course we had the huge blessing of the vaccines, the NHS then mounted the largest ever mass vaccination programme in its history across the whole of Wales. And actually the NHS, I think, quite often led the world in its rollout. As a member of my senior team remarked to me in the summer of 2020, and this is stuck in my mind right through the pandemic, when given the opportunity, the NHS can work as fast as the army and with the creativity of Google. I think that's something we need to reflect on. My second lesson, and I kind of knew this before the pandemic, but it was really brought into sharp focus during the pandemic response, is the NHS is full of amazing people. Our teams, not only the front line, but right across our organisations, ran towards danger, showed persistence and resilience, and made personal sacrifices to care for our patients. We learned quickly that it was hugely important to ensure that there were places for staff to go, to unwind, to take a moment and process, that having access to nature and being given the time if they needed it was important. For those struggling the most, we are providing in Hywel Dda, for example, retreats to nature courses, structured time out from the day job to help people to process and recover. Of course, as a vocation, work in the NHS is hugely rewarding, but it is more than just a job. And we as boards need to ensure we care for the whole human being that works for us and not just the employee. My third lesson is again something I knew before the pandemic, but has been demonstrated with a stark and I think uncompromising clarity in the last 3 years. And that's that the NHS is important. It provides certainty and continuity at times of national crisis. As we entered the pandemic, our communities rallied to protect each other and protect the NHS. Many people felt moved to help in any way that they could. The NHS was a focus for people to organise around and to support. We all know the NHS is far from perfect, but it has been alongside people their whole lives, offering help when people are at their most vulnerable. And the pandemic response we saw from our local population showed that this is a two-way street, supporting us so that we could support them better. As with many of the challenges we now face, much of what I've just described was there before the pandemic. If there is any good to come out of the events of the last 3 years, though, it is that it will allow us to refocus on these things, the things that really matter. In my 30 years in the NHS, I don't think I've ever known a time when the NHS faces so many challenges. The road ahead is deeply uncertain, with a huge recovery effort underway, tired staff, as well as growing staffing gaps, adding to the pressure that they are already feeling. The biggest cost of living crisis in 30 years, and of course big challenges more generally in the public finances. If the future looks challenging, I believe we can nonetheless build a better future by using the lessons we've learned during the pandemic. Firstly, we need to find ways to keep that sense of empowerment of our frontline and corporate teams in a much more complex world post-pandemic. There are a number of things we can do to achieve this. For boards, staying out of the how and giving autonomy and responsibility to our teams, clinical and managerial, stands the best chance of harnessing the creativity and deep knowledge of people who know the business. This is tough for boards, as we like to think we know how to do things, but staying much more in the why, our long-term objectives, and the what, our specific quantified aims over a shorter specified timescale, allows us to ensure we are moving in the right direction, whilst the whole organisation coalesces around the efforts to get us there. This needs to be coupled with long-term ongoing investment in our people, skills to allow everybody to maximise their potential, nurturing everyone's leadership skills, promoting the importance of compassion and civility in the workplace will allow our people to do remarkable things. We also need to think about the environment in which our staff work. Our infrastructure is generally poor, but we need to do our very best to provide rest space, places away from the immediate pressures of the day. We also need to invest in staff time to get away from the day-to-day, to develop their skills or undertake research or quality improvement work, for example. We also need to think more about the role of nature in the way that we design our facilities. Research is increasingly demonstrating that biophilic design not only helps patients in their recovery, but also creates an environment for our staff which supports their well-being. In Hywel Dda, we're looking to develop a new hospital, as well as to repurpose 2 existing sites based on biophilic design principles. I think a first in Wales. And finally, recognising the central importance of the NHS to people's lives, and indeed the vital importance of our communities to the future of the NHS, we need to focus our efforts much more on deeply entwining our NHS with our local communities. We can do this in a number of ways, such as reducing the barriers our local young people often face in gaining clinical and managerial qualifications. Our apprenticeship scheme and Grow Your Own programmes are based on the character and values of applicants, not their formal qualifications. The deal is, if you have the right attitude and values, we will get you through your qualifications and pay you along the way. This is a perfect demonstration of that two-way street we saw during the pandemic. We need our communities to come and work for us, and our communities get long-term, well-paid jobs that can often break cycles of poverty and deprivation. We also need to bring our anchor institution status much more to bear, developing our local supply chains and supporting local businesses. We are doing this with the power of research and development programs. Tritech in Cynhadledd is a great example of this, as well as through our early work with local building firms and our local colleges to develop the apprenticeships that are going to be needed to help us build the new hospital and maintain our sites going forward. And finally, on this subject, we're working hard to shift the whole model of care from one which is based on fixing problems, a medically driven model, to one which supports our local people and communities to be resilient and support each other, so that hospital is not the default response to a problem which is increasingly often a mix of social and medical issues. We call this our social model for health and well-being. Getting this right will change the relationship we have with our communities, our partners, and the third sector, and will result in an NHS which I hope is more deeply rooted in the support structures that underpin our community's resilience and cohesion. So I therefore hope that the lessons we've learned from the last 30 months will prove to be a starting point for a new chapter in the NHS's history. But given the challenges we face, it's going to require everyone's effort to make it a reality. Thank you.
We won't let you go for a minute because you've been a good boy on time, so we'll take any questions. So if anybody on the floor has a question, do we have any online? Yeah, we do, but while Anna's digging that out for me, Steve, I just, as an old member of this crew who's heard many things over the years, people have been talking about this change of making the health service a wellness service rather than a health service fixing problems for many, many years. Do you think COVID is the kick that it needed to make that a reality?
Yeah, interesting question, Jack. And I think it was already happening, probably a lot more slowly than it should have done. I was rereading, for those of you who might remember, the Derek Wanless report a few weeks ago, which was written back in the year 2002, I believe. And in that, he had a chapter called The NHS in 2022, which is a really interesting read. Actually, we should have started back then with what he was calling a sort of fully engaged model, which is much more about that sort of intertwining that I talked about in my opening comments. But I do think we were on the way to that before the pandemic hit. But I nonetheless think you're right, Jack. The pandemic has demonstrated both the need to do that more quickly, but also the strength and resilience of our communities to be willing to do so. So I think we do need to pick up that effort, and that kind of new chapter I talked about at the end, for me, is as much about how we really give that the kick now that it needs coming out the other side of this.
Yeah, thanks, Steve. I started on this journey with Mr. Wanless at much the same time. So, and one other quick question for you, Steve, which was you're talking about the staff doing amazing things during COVID and coming up with solutions to problems. So in the past, there seems to have been a sort of rather thick layer of treacle people had to wade through to get innovation started. So rather than trying to replicate examples of great practice, do we need to empower staff who have great ideas to do what they need to do?
Yeah, and I think that is a central challenge really for an organisation as big and as cumbersome as the NHS. We've got all sorts of layers of governance. A lot of it for good reason. This is taxpayers' money that we're spending. But I think what the real lesson, the real clarity we learned as a board during the pandemic was the board absolutely needs to set direction and set out what it likes to achieve, what it wants to achieve, and it needs to do that. Set that direction with both its population and its staff engaged in that discussion. But once it's got to the point where we think we know what we need to do, is to stand back and allow our teams to work out how to do it. I often say with much love in my heart, but if the executive team and I were sat around trying to work out how to build 9 field hospitals back in March 2020, we probably would have still been talking about it in July, and they got opened within 12 weeks because the teams just knew what they were doing. So it does require a bit of trust. It requires a bit of letting go by boards. But I think it also links to the other things I was saying around developing people's skills, leadership skills at all levels, and allowing people time out of the day job to think about improvement and what they can do in their own realms. We need all of those efforts really to push us forward. So it is something which I think we in Hywel Dda been on a bit of a journey of. It is cultural as much as anything else, but I'm hoping that we will have light touch but effective governance and a much more sort of innovative, agile kind of model going forward.
Yeah, thanks, Steve. The audit and risk committee, or whatever committee it is, has to find a slightly different way of working, I think. But that's for everybody across the whole of the health service, I think. And as I said, I started when Mr. Wanless was about. There was also a terrible thing about Mr. Shipman being about. So the risks are understandably needing to be managed. So thank you very much, Steve. And can I just say that you were competing against the most amazing rainstorm here on the roof of this building. So I hope everybody could hear you clearly. Thanks, Steve. Thank you very much.
Jack. Thank you. Cheers.
Great. And do we have Kate online? So now our next presentation is from the Powys Teaching Health Board, who cover this neck of the woods. And we have Kate Price, who's the medical director. Kate, over to you.
Hello, everybody. And I'm so sorry I can't be there in person today. I'm standing in. Carol Shillaby was going to be here, but she's been called to do something that she couldn't not attend at short notice. So I'm here instead. So I'm the medical director in Powys, and I've been working in Powys for the last 18 months. All very new to me. I was an emergency medicine consultant for about 20 years before that. So I've had the best time in Powys, rapidly learning about community services and all things rural health, which has been absolutely brilliant and continues to be brilliant. I've got a few slides. I can echo a lot of the sentiments and the things that Steve shared. I'll just share my screen now and then tell you where we are in Powys. So yeah. So is that sharing? Just can people see that?
Thanks.
Yeah, thanks. Great. And I can't get it to move on typically. In which case we will just talk through. Is that moving on for people? No.
Do you want Anna to share it here, Kate?
If she, yes, I thought I was so organised. If she could, Anna, is that okay? I'll probably not use them. I probably won't go through them all, but if I'll just tell you which ones we'll flick through. Thank you. I even practiced beforehand and it still goes wrong. So sorry.
Hang on, we're getting it up now, Kate, with a fair wind.
Thank you very much. That's brilliant. So yeah, so the slides really, they're just trying to outline where we are, what's important to us and where we want to go. Importantly, in Powys, it was way before I started, but about 5 or 6 years ago, the health and care strategy was developed, which was a joint strategy against between the health board and the local authority in social services, which is still is as relevant now today as it was then. Anybody that knows Powys will know we talk about start well, live well, and age well. Principles, there was co-production with the community, so the principles very much are about early prevention, well-being, co-production with communities, and when we look at what we're doing, quite often we reflect back on it, and much of what we do still stands with that. So that sits as our local plan, which fits in with the regional or national plans. Obviously, there's quite a lot of change going on in Powys at the moment. We've got a new cabinet, so there are changes happening around the RPB, and we continue to develop our strategy, and it's held itself throughout the pandemic as well. So if we can move on to the next slide, please, Anna. Thank you very much. So this is where we are. I think the critical priorities are probably what we spend most of our time talking about, or a lot of our time talking about, and everything fits in around them. So access, flow, workforce and finance occupy a lot of the execs team's thoughts and attentions. Self-explanatory, really speaks for themselves. The access is incredibly important. We were working really hard. We were well publicised and well-known issues about access during the pandemic, and we're just doing everything we can to make sure our patients are getting care as close to home as possible, and that's what we're all about. We've got lots of medium and long-term strategies, a lot of focus on prevention. I think at the moment, then there's so much changing. I don't think I've ever known in all my years working, I don't think I've ever known a climate that is changing so rapidly. And there's a real risk then that that we focus on the here and now and the firefighting all the time, rather than taking our eye off the ball, which we know is really important, which is the long-term preventative strategy, healthcare initiatives. So we're really trying to keep an eye on in both lanes, an eye in the sort of the fast and here and the now lane, and an eye in the long-term lane as well, because that absolutely we know that will get us where we need to be. It was quite heartening yesterday. I was at a workshop looking at mental health services in Powys, and we drew up a huge list of initiatives and thoughts, and then everybody was asked to prioritise, and almost everybody's dots went into the preventative lane, which is really encouraging, really where we need to be, but it remains a challenge given all of the distractions we have on a day-to-day basis, but really at the heart of everything we're doing. Primary care, most of you probably know that Powys doesn't have a DGH, which brings its challenges, but also brings its opportunities and makes it very interesting. Also helps us really focus on our strategy to provide as much care as we can as close to home as possible. And I have to say, having been there a year and a half, I've been really struck by the amazing workforce that we have, who really are very dedicated, have remained resilient throughout the pandemic, and even now are smiling and motivated and getting on with the job, which is absolutely fantastic. There are massive opportunities in the communities at the moment. I think there's a real focus on the communities, rightly so, and so we are really trying and hoping we can lead the way in transforming our services, using what we've learned in the pandemic to transform, not completely change, because a lot of the things we do work already, but really to use a new tech, use new methods of working, new thoughts and ideas to start to treat more people at home, or facilitate them having care in secondary care facilities more easily. So various areas of focus. The accelerated cluster development is really important for us, a huge amount of work to deliver, but actually is really going to start to focus attention on what's happening in our communities and the way the communities are involved and integrated into delivering some of the service. A lot of work. Diagnostics is really in the headlines at the moment. We know that diagnostics are a rate limiting step for lots of the services. So we are really looking very closely at how much we could do in Powys and how we can help to facilitate getting diagnostics to our patients more quickly. Our big four are part of our health and care strategy, which were outlined as being cancer, circulatory, mental health and respiratory. And so there's lots of work ongoing in delivering some of those services that will be traditionally provided in secondary care facilities in the communities, and that's been very successful. We've got a large frailty and community care programme and an urgent care strand, all of which are progressing, which is great, and all of which are really, there's a real focus on trying to make sure they're clinically led and clinically led by the services, which is helping us to deliver them. Okay, next slide, please. Thanks, Anna. So again, lots of enablers for all of these, lots of different drivers. So, and actually, so lots of different initiatives have come our way. We've got the Planned Care Transformation Modernisation Programme from Welsh Government, the 6 goals work, the ministerial priorities. When we look at those, they generally fit into our existing strategies. So a real challenge, it's a very busy time. There are so many different competing priorities that a real exercise is in trying to streamline, trying to prioritise and trying to make sure we're not duplicating work to produce as simple a system as we can. We're working closely with GIRFT, which is helping us learn a huge amount about our services. It looks very different for us because we don't provide as many of the services as other health boards do, but nonetheless, it's been a really interesting exercise. It's taught us, for example, that in orthopaedics, then currently, sadly, because of the waiting times, our patients are getting a better service in England. So it's helping us learn from what other health boards are doing and helping us. We have a bit of a bird's eye view in Powys because we commission service from so many other health boards. We get a bird's eye view, which helps us to learn and helps us to share learning across the system. Next slide, please. So transformation and value. Value is, as I'm sure it is for other health boards, really at the heart of everything we're doing, and it is really a huge enabler and a really important anchor for all of our initiatives and for everything we're doing. So we've got a lot of exciting pathways and exciting initiatives. We're doing work on wet AMD. We already provide some service in Powys, but we're looking to see how we can expand that to provide more of the service in county, and looking at things like biosimilars, which we know will bring value and maintain outcomes for our patients. All of our renewals priorities are based on value-based modelling, so lots of value-based pathways being looked at for frailty, falls, lots of value-based work looking at in MSK. We're developing a community heart failure service, which is really, really exciting. We've had a GIRFT review in gynecology, which is helping us look at how we can transform our service, and the lymphedema work as well. As I said earlier, lots of work on diagnostics. Some, we don't have scanners in Powys. There was a school of thought that perhaps we didn't need them, and then just looking at the overall work, looking at the backlogs, looking at the difficulties our patients have in accessing scanning, then we are really positively considering how we where we would have scanners in Powys, because I think it's increasingly looking like it's part of the future. It's almost going to be like having an X-ray before we know it. So we need to change the conversation. We need to really be demonstrating what can safely be delivered in our communities, and scanning is one of those things. Lots of other diagnostics. The respiratory programme is doing, we've had drive-through spirometry, lung function testing, pro-BNP for heart failure, lots and lots of other diagnostics that we're looking at as part of delivering some same-day emergency care without a DGH, which again is quite exciting. I think the GPs are doing a huge amount of same-day emergency care without a dedicated building or facility, and a lot of that goes unrecognised. So we are doing a lot of work on pathways to make sure we're doing it safely, to make sure we're doing it efficiently, and pathways that will grow into a bigger and more robust same-day emergency care service, but without a DGH. Medicines management has been very, very active in doing a huge amount of work, looking at medicine safety, looking at optimal prescribing and sharing information across the whole organisation. So sharing information with clinicians on the prescribing practices, and we've got good evidence that by doing that we are improving practice, reducing unnecessary prescribing and making prescribing and medicines management safer, which is being very well received in all areas of the health board. Lots of work on prehabilitation and rehabilitation, which is well rehearsed, I think, but again, really exciting when it comes to the preventative arena, and is growing and growing all the time. Okay, next slide. Thanks very much, Anna. So I've already talked about our renewals priorities, and these were developed as we were coming towards the end of the first stage of the pandemic, when we were looking at regrouping. We did a lot of work looking at what we'd learned from the pandemic, looking at public health projections and modelling, and looking at what was most important for our communities, and came up with our renewal priorities, which have really been about learning from the pandemic, about making sure that those patients that have been delayed access to care as quickly as possible, and then making sure we transform and really optimise and maximise our transformation from our learning. So we have insourced, and that has allowed us to catch up with our waiting list, which has given us a bit of breathing space to really look forward to transform. We're looking at our cancer pathways very carefully, and the rapid diagnostic centres. One thing that happens in Powys is that because of our huge geography and small population base, then there's a lot of inequity in terms of access to services. So rapid diagnostic centres are a huge step forward. But not all of our patients can access it because of geography, and because we commission it from surrounding health boards, some of whom are still developing their services. So we're also looking to see whether we can provide that in county. We're doing a lot of work on children and young people, because we know that by early intervention, then that improves all of their outcomes, which is where we're at. We've talked about diagnostics in GIRFT. The North Powys Wellbeing Programme, again, many of you will be aware of, but that is I was up there yesterday, very exciting programme looking at an integrated model of community care for the north of Powys, due to be based in Newtown. The plans are progressing really nicely. So the PBC has been approved and the strategic outline case is being worked up. Lots of the work I've talked about, lots of the renewal strategies, our transformation programmes, all fit around the North Powys Wellbeing Programme. So all of the conversation is about how, by transforming our community services now, that will feed into the plan for North Powys. The overall ethos is very much looking at how much more we can safely provide, how much more care we can safely provide in communities, looking at sustainability is a word that we talk about all the time, looking how, and I think these are opportunities. I think we are seeing all the time as we develop our services that we're developing new roles, really exciting roles, and roles that can work across different specialties, different disciplines. So as for us, then that is starting to help with our sustainability concerns by developing roles and teams that will have a really rewarding and interesting job space within the communities. We really hope, and I think we're starting to see that we are starting to get a little bit more sustainability in our staffing bases. Really challenging for everybody at the moment, but what we are really actively trying to do is to create really really worthwhile, interesting jobs within our communities that our communities will want to stay and work in. You'll be aware we've got our health and care academies, or I've gone off piece a little bit, Anna. The health and care academy isn't there, but that is another really exciting development whereby we are working. It's a joint resource across health and social care, where we're going to be training staff to work in Powys and live in Powys, and that is really important for our future workforce. And is a bit of a blank canvas, so many of the initiatives there will be based upon the need and the roles that are developed as our plans as we develop them. Okay, last slide. Thank you very much. So I think this is my summary. At probably the most challenging time for most of us, and there's no doubt we've been through a hugely difficult 2 years, and we know that we've got a hugely difficult time ahead. There is also massive opportunity. I don't think I've come from secondary care. I worked in acute care for my entire career, but I knew when I was working there that bluntly, for us to be able to get our patients, the patients that needed to come in through the front door, then we had to have the right community infrastructure. So even as an emergency medicine consultant, I was constantly talking about the communities. And I think, never has that been truer than now. There is a real focus on community care and rural healthcare, rightly so. And so there really is an opportunity now for us to lead the way in developing our community pathways, in developing our joined up community and secondary care pathways, and getting to a more sustainable position that we need to get to. So whilst I think we all feel the challenges ahead, I also think we all have some optimism in that by realising even some of the plans that we have, we are going to start to get to a more sustainable position, and we can, as a rural community and rural communities, especially by working together, we can really, really show how it can be done. I shall stop there and be very happy to take any questions.
Thank you for that, Kate. We'll take a couple of questions for you if anybody has them from the floor. But just listening to what you were saying, Powys has always been at the forefront of some things because you don't have a DGH of your own. And I was wondering how far you think we're going to go down the line of what traditionally were called secondary services, that you'll actually be a provider of what we traditionally called secondary services rather than a commissioner of it. Can you see the day when you will actually be providing, say, orthopedic surgery in your communities by either remote robotics or something? If we'd asked 20 years ago whether all these diagnostics would be in the community, people would have said no. So do you see that as the future?
I think the answer is yes, absolutely. There's and I've been here 18 months and I'm still learning. So I think there are some, it's about pathways, I think, and there are some very clear pathways that can be delivered in remote communities. That we've got some really lovely theatre facilities, and there's a huge number of things that can be done as a day case. So we're actively scoping that. We provide some very minor orthopaedic surgery at the moment, but there is interest and support to start to provide more day case surgery. The approach that we're taking really is pathway by pathway, rather than we can't suddenly implementing huge change is very challenging in the current environment, but by implementing and testing pathway by pathway with our surrounding secondary care providers, then absolutely we can do that. So yeah, that is absolutely part of the plan, not just orthopedics, but other areas of surgery. I think day case surgery is something that we can do and that we can excel in. and it's about taking small steps to make sure we work towards it in a safe way. But we've proved the insourcing has been very, very successful. The insourcing teams loved the theatres, they loved the environment, and in a way that was a bit of a test to what can be done. So the answer is yes, and with some confidence.
Great. And there's a couple of questions come in, Kate. And the first one is, what plans do you have for dentistry to make it more accessible in rural areas?
So yeah, so we and again, I think the difficulties with access to dentistry during the pandemic are well advertised. Been working very hard in Powys to maintain access for our patients. There have been a couple of bumps, but on the whole, the service has continued. We've got really strong dental leadership, and they're ambitious to continue to provide the service, but also to develop the service. So only a couple of weeks ago, we were looking at how we continue to sort of sedate safely, for example, for certain cases, and we work closely. I think one of the challenges in a rural community is that of support for lone workers, isolated workers, peer support. So really important that we maintain links with our surrounding secondary care providers so that we've got our practitioners working in a supported environment with peer support, peer review, and that's something we're working very hard on. So it's work in progress. I think dentistry isn't easy and hasn't been easy, but we're in a relatively stable position at the moment, and we've got really good teams who are motivated to take that forward.
I think any medical director would probably be asked a question about dentistry at the moment. And there's another question is, how do you work with communities and the voluntary sector to develop your ideas and plans?
Yeah, so yeah, I probably didn't mention that in should have done. So very much as part of the health and care strategy, then it was a partnership piece of work. We work very closely with our communities and voluntary sector. So, for example, I chair the Frailty Programme Board and the Cancer Programme Board, and we have representatives there. The voluntary sector come to our cluster meetings and our system resilience meetings. So we do work very closely with them in partnership, and I can only see that getting stronger and stronger. So again, looking forward, then what's really important is that we develop pathways together that that really align, make sure we don't have duplication of efforts, and that we're working together to provide the services. But one of the things I love most about working in Powys is that a lot of the services are already community supported. And so if I'll ask a question about falls somewhere, for example, I'll be told, well, there's already a community team that does that. So we do have advanced, really excellent and advanced relations. Not to say they can't be built on more, but I would say the voluntary sector is involved in most, if not all, conversations, and rightly so.
Great, thanks. I think your time is done, Kate. So thank you very much indeed. And we will move on to our final 20-minute presentation in this part of the morning, which is from our other sponsoring health board, which is Betsy Cadwallader. So Chris, are you there?
I'm here.
Ah, even better. Just for those of you online who are seeing far too much to the left-hand side of my face, I keep looking at the presenter on the screen, so that's why you're seeing my left-hand profile. Chris, thank you.
So the risk of going third in one of these sessions is that everything you were going to say has already been said. But I will try to introduce some new material. I'll just wait for the slide set to come up.
It's never great going third.
No. Okay, thank you, Anna. The eagle-eyed amongst you will realise that the picture is Lake Vernouillet, which is in Paris and not in Cynhadledd. I deliberately put that photo in because I was looking forward to a nice autumnal drive down here this morning. It didn't look like that. I'm hoping it might look like that on the way back. So I'm going to talk just a little bit about some of the past learning, and I will touch upon some of the comments that Steve and Jack both made. Give a few examples of that past learning in present context. And then just a few thoughts about where we think things are going and some of the challenges. So COVID. COVID has obviously impacted upon us all in lots of different ways, but I don't think it's impacted anywhere any more so than it has upon our rural communities. And whilst it's challenging, our learning from COVID has such a potential now in terms of helping us understand some of the opportunities for rural health as we go forward. We've found some shared endeavours. We've got coalesced around some common themes and found ways to make them work. We've found a pace. What used to take years has taken weeks. What used to take months has taken days as we've worked through COVID. We've actually worked out how we work in partnership, or at least we've started to work out how we work in partnership, and we've really started to understand really what the value of that is. And I'm speaking through a health lens, but we're not always as good as we should be at working in partnership, and we're not always as good as we should be at recognising other people can do things better than we can. We started to understand what matters, and just as important, what doesn't matter. And we've really started to understand that there's a wide range of skills out there. Many people can do many things, and perhaps we shouldn't be medicalising everything because other people do just as good a job, actually often a better job than we do. And we've seen that all the way through COVID. And then, of course, digital. We've talked about video consultations. I'm going to give you some other examples of how we're using video technology. But the world has moved so much further forwards in terms of digital health as a direct consequence of COVID. Of course, if you don't like digital, then the world has moved a long way backwards too. And we've got to work out how we make digital work for everybody, but I'll come on to that. But most importantly, we've started to return to a time when we really start to understand people, what really matters to me, and that's often not what other people think. We've started to have those conversations again. We've watched some horrible stories over the course of the last few years, and it started, I think, to remind us what this is all about and what value really does mean. I'm going to give you a few examples. They're only examples of some of the things that we're doing that have a little bit of a rural perspective and which touch upon some of those themes. And the first I'm going to tell you is of a trial that we're currently doing with Imperial College in London, looking at this little gadget. It's about, what is it, about 3/4 of the size of your smartphone. And the trial is called the Tricorder trial. And put simply, this is a little device that any clinician can just pop onto your chest. And within about 15 seconds, it will give us a reasonable clue as to whether or not you may have heart failure or you may not. It's not 100% accurate. Find me a test that is. It's a screening tool. But how fantastic is it to be able to do that within 15 seconds in your own community, then have to travel all the way to the nearest hospital, clinic, or you know, big hospital for a whole battery of tests. I'm prejudging what the trial will show, but this is the sort of stuff that we need to be looking at and exploiting, because we know that our rural communities are often less likely to ask for help for a lot of reasons, including the very, very obvious and simple factors of actually it's a bit of a pain in the neck to get to hospital to have the tests. I'm actually not that bothered. I'm just going to let it ride. And we have to do everything to find these opportunities, and we're really pleased to be involved in this trial and see where this goes. I can't think of many things worse if I had difficulties with my hearing and required hearing aids, and those hearing aids were malfunctioning, to then have to take 2 or 3 buses to get to the nearest audiology clinic to have my hearing aids checked, just to find out it was a really simple problem that could be fixed. So one of the things we've done is introduce a virtual hearing aid clinic. Now, this doesn't work for everybody. And if it doesn't work for you, we have other solutions, going back to the traditional solutions. But the feedback from plenty of people for whom this has worked has been great. Keep it. It's a fantastic idea. It's really helped. We can have a video consultation with you. And if it's a nice, simple problem, we can fix it without you needing to come up to the audiology clinic, like I say. Really simple idea. We tested it. It seems to have worked. We're now trying to roll it out more widely because, of course, this would work just as well in an urban population as perhaps it would in a rural area. I'm a little bit embarrassed about this one, and it's not because of the subject matter, but it's because this is such a simple problem that I can't really understand why it's taken COVID to get it fixed. Something in the order of 30% of folk pitching up to our sexually transmitted health service have waited for 3 days after having a diagnosis to then getting their prescription to start treatment. And that's simply because in Wales we don't have a reliable process to transmit prescriptions to a pharmacy. And so people have been asked to go back to the sexual health clinic to pick up the prescription. It's pretty ridiculous, really, when you stop and think about it. And you would not believe the amount of governance that has been involved in unpicking this one. But we have unpicked it, and we've now got to a position, at least in parts of North Wales, where that prescription can go straight to the pharmacy. The pharmacy will dispense it without you then having that roundabout journey, which was altogether unnecessary. I'm really pleased about this partnership. In Penrose, just outside Pwllheli, there is an old Second World War veteran Polish community. And it was a hospital, fallen on difficult times, and went into financial difficulty a few years ago and had to close. Now, at that point in time, we were already struggling for community placements in the Clean Peninsula, and more care homes closing. Really difficult situation, and this just added even further stress to that situation. We knew that people were moving out of the area, away from their families because of that. Now, it's challenging for health services to provide residential care services. It's also challenging for health services to borrow money to build buildings. We've entered into partnership with the local authority and with a local housing association, and between the 3 of us, we're providing or are starting to develop a site here where the housing association is able to borrow the money. The local authority is able to help with a residential care experience. We're able to help with a nursing care experience, and together can provide a village for retirement, which allows escalating care for local residents who then don't have to move away from the Clean Peninsula. It's absolutely what we should be doing, and none of us could have done this on our own. I'm going to tell you about the virtual joint school. Now, there's lots of evidence to say that if you're going to have a hip replacement or a knee replacement, then if you go to joint school, it helps you in terms of managing any anxieties that you might have, and it increases your success afterwards in terms of your recovery, because you know what to expect, and people have talked through the exercises with you before you've had your surgery. It's not particularly easy to travel from a rural area up to a DGH when you've got a dodgy knee or a dodgy hip. And actually, when you get there in joint school, we don't ever examine you because that's already been done. It is simply an educational session. So we've had a few plays at this and found an approach now in North West Wales which seems to work for us, where we offer a virtual school opportunity. People are able to build relationships with each other and share their own stories and build their own networks as patients. And we're able to do everything here that we were able to do in the real in-person joint clinic that people were previously invited to. Now, you can still go to that if you want to do, you have the option, but this is fantastic for those people that would much rather join from the comfort of their own home. The last of my examples is on the Tywyn managed practice. Now, as a health board, we have, unfortunately, quite a lot of experience now in terms of running struggling practices, most of them in urban areas. Here we had a practice in a much more rural area. Now, in an urban area, you can build practices together so that you've got the critical mass for lots of other professionals to come in and support the GPs. In a rural area, you have to do the opposite and find ways of expanding the scope of those professionals so that there is enough for them to do. So in Tywyn, we developed a service with WAST where we have used advanced practice paramedics. Fantastic feedback from everybody involved there. We've built a service around our practice pharmacists so that they're able to support our GPs. And we're now starting to develop an education hub there so that we can attract in those professionals that want to work in a rural area and give them those best opportunities, and are starting to see a growing interest. Now, this is an early piece of work and we're a little way away from where we want to be on this, but I think it shows us some potential for where we can do things a little bit better. I've included this picture on my last slide a little bit facetiously in terms of what does the future look like. It definitely involves technology. I hope it doesn't look like this, because I don't think this is the right way of using technology. We can't lose the humanity out of healthcare as we go down that technological journey, and we have to find that sweet spot. We've got to make sure that we bed in the COVID-19 learning and make it our usual practice, and we're a little way from being in that position yet. We're already seeing some of our video consultation rates decrease a little bit as we come out of COVID conditions. So there is a little bit more work to do in terms of finding that sweet spot. And there is a lot more work to do in terms of how we support people who don't have access to technology or who through their rural locations are excluded from being able to access adequate technology. But those are challenges we've got to bridge rather than reasons for not doing this. Different doesn't have to be worse. And actually my challenge out to the conference would be, we need to find the solutions that our urban areas are then wanting to borrow and find ways to adapt, to use, rather than what has often been the other way around. And my last and parting point really is we absolutely must not lose the resurgence of understanding in social health. Being drowned out by the rain again now, but social health and well-being is so important in this moving forwards. We recognise now that good health and well-being is not about pills and scalpels and doctors. It's about far more than that. And if we lose that from our COVID learning, then it's at all of our detriment. So a lot of food for thought for us as a health board. I hope some food for thought for the conference as well. But really exciting times as we move forward, I think.
Thanks very much. Can you hang on a minute if we have a question for you? Do we have a question from the floor at all? Yeah, sorry, can you rush over with the microphone, Anna, to the back there? Thanks for that, and thanks for fighting the rain.
Fortunately, just the last of it.
Yeah.
Yeah, that's a fantastic question, and I should have included something on that. And conversations continue to occur with our transport providers, both public transport providers, but also the voluntary sector and ambulance services, and you know all other manner of providers. I've spotted Jackie from our CHC sat over in the corner, and I don't think a CHC meeting goes by without the issue of transport coming up. So it is an issue that we are all live to. Of course, there is a balance between expecting people to use transport to come to us and us reasonably going to communities. And there is, I think, a lot more work that we need to do, and which I probably should have covered a little bit more in terms of how we can move out and provide more kind of hub and spoke services into local communities, because it isn't appropriate to expect everybody to travel to a hub when we can perfectly reasonably provide that service in other ways. We all have to think differently.
Thanks for that. And Jackie, quick question from you. I was going to say that leads us brilliantly on to the next speaker, but Jackie's interrupted.
Strategies. I feel very strongly that we should be looking, especially if you want to get community involvement, into a longer term, and by longer term, I mean a 10-year or even 15-year strategy. Because people don't take on board the commitments, especially within the volunteer sector. And I honestly think that we should be looking further into the population bases, etc., to get the strategy working properly. Because once you start on your three-year plan, you just started it when the 3 years are finished, so you have to start all over again. So I'd like to perhaps stress that. Thank you.
100% agree with you, Jackie. Yeah.
We'll have to have an election, only 15 years, Jackie. I don't think anyone would disagree that a longer term view might help. Thank you, Chris. Right, the question before was about transport, and I'm glad Chris didn't do too much on transport, because our next speaker might have been a bit upset. So I'll now hand over to Charles, who will do the next talk, and he's going to talk to us about transport. Charles.
Great, thank you very much. That was nearly a perfect segue into my talk. So delighted to be here. Thank you very much for inviting me along. I'm Charles Muswhite. I'm Professor of Psychology at Aberystwyth University, and I have an area of expertise, and don't ask me how you get into these things, but in transportation, and particularly the people element of transportation. And what I wanted to do today was do a presentation. I've got a little clicker. A presentation for you today, taking you through a new project that we've just been funded, if I can fight against the rain, by Health and Care Research Wales, which looks at the relationship between transport and mobility and getting out and about, and the health of individuals and populations as a whole. So that includes both things like access to healthcare, as we've been talking about today, but also the effects of mobility on people's health and well-being. Really important if we're thinking about people's health in communities and maintaining health. And I think rural areas in particular have particular issues in both those elements. And I've got some figures to try and explain that in a minute. And it might all seem a bit doom and gloom to begin with, but bear with me. I think I end slightly more positively towards the end. And hopefully I'll be able to pick up on some of the things that were mentioned by the chief executives and the strategy that was talked about in the trusts earlier on, because there's some excellent stuff going on there. And it's just the kind of thing that needs to happen, albeit with transport involved in some of those decisions, and we'll be all right. So we've got a new project, like I said, it's called THINK. So it's the Transport and Health Integrated Research Network. We're really here to pull together people working in both transport sector and those working in the health sector, and try and get them to work together. Since I've started studying this probably 25 years ago or so, although I know I look younger than that, so a bit surprised there for you all. But 25 years ago, it was always a thing that transport and health needed to work together more closely for a number of reasons, both accessibility and, like I said, the impacts of transport and mobility on health. And there was lots of moves towards doing that and bringing that together, but it still hasn't really worked particularly very well in reality. And the two still don't talk as closely as perhaps they should. And rural areas with big high social capital happening in communities, there's a real opportunity perhaps to bring those elements together. And I think Steve outlined some of that earlier on in the answer to the question. Work with the local transport planners, work with the bus companies, work with local government, that kind of thing, and try and bring it together. So as I say, we're funded by Health and Care Research Wales. We've got until July 2024 to bring people together. What we want is everybody to get involved. So do sign yourself up to it. At the end, there's a website and an address to sign up to. It's led by myself and Sarah Jones, who's a consultant in environmental public health at Public Health Wales. And we've got Dr. Lucy Baker and Amy Nicholas working with me at Aberystwyth University to make the project work. But really, to make it work properly, we need everyone to sign up to it. So there's 4 particular areas we look at, as well as access to healthcare, which I think, of course, is important. But like I said, we want to know the impact of transport and mobility on people's health. And it's those particular 4 areas there that we look at. So the impact of vehicles in terms of air and noise pollution on people's health. So some of that shorter term, some of that more impacts over the longer term over somebody's life course. And although, again, I think we tend to think of rural areas as being relatively pollution free, there's some really big hotspots or areas of high air and noise pollution because of the main road and the concentration of villages and towns around those main roads, which make them every bit as bad in some cases as urban areas. And again, as I'll come on to at the end, lots of the strategy that is invented to improve things like sustainability or to improve health around transport is often very urban centric. So we have air quality management areas and things like that over the past sort of 10, 15 years, largely concentrated in urban areas and not thought about so much in rural areas. So that needs to change a little bit. Road safety is another area of particular interest. The worst road safety is found on national speed limit roads, so 60-mile-an-hour roads, of which there's an abundance in rural areas. That's particularly bad where they meet a town or a village again, and there might be people walking or cycling in those areas as well. So where they move from 60 to 40 to 30, they're the worst areas. So again, rural areas overrepresented in road traffic collisions that result in injuries and deaths. And the impact of active travel. There's some interesting stats I'll show on that in a minute in terms of rural areas and lack of walking and cycling in those areas. And of course, that's something that can improve people's health if we do more active travel. And there's also the element of mental health. So cars and mobility can join things together and join people together and help access things in the community, whether that's healthcare, social care, things you might want to do, leisure pursuits, jobs, things you might not want to do quite so much of. And that impacts on your mental health, but it can also be the other way around. If you create isolated communities or places that are hard to connect together, whether that's because there's a great big, huge road through the middle of a community, severing one side of the community to the other and making it difficult to access one side or the other unless you use a vehicle, or just very poorly joined up communities because they've become very car centric over time. We'd have a look at this in terms of demographic change. So things like the life course, we want to see how things are impacting on rural areas where there's an aging population in particular. We're very interested in inequalities. So access to transport and health in terms of inequalities is really important as well. Not everybody has the same opportunity to access things they want to do because they've got different levels of mobility and therefore different health, and we can't have that being an issue. And look at that within a systems approach. That's why it's important to bring people together from different backgrounds, and a healthy communities approach, so that community and the individual within that community maintaining their own health. So this is an interesting statistic because it's probably not necessarily something we don't know, but it's quite evident that people in rural areas, as evidenced in the blue bit down the bottom there, and the more rural you become, the more miles you have to do traveling to do the same kind of things that you would do in an urban area. And you can see that an issue because the number of trips people make, and the Department for Transport classifies that as a journey for a purpose somewhere and a journey for a purpose back again, is the same. So people aren't doing more journeys in rural areas because they want to, they're doing it because they have to for the things they want to do. It's almost identical to urban areas, but they have to spend longer doing that and they have to spend more miles doing that. And that therefore impacts on people's health. Most of that in a rural area, and sorry for the colours in the graph have changed here because Department for Transport have changed their colours over the last couple of years. But most of that is done as in a car, and and that's the mode of transport that has the most negative impact on individuals' health. So in rural areas, much more likely to use a car for those journeys than you would do in urban areas. And not surprisingly, people are much more likely, therefore, to own a car in rural areas and less likely not to have a car in rural areas. And if they're negatively impacting on health as they do, that means that rural areas have more problematic issues as a result of using vehicles in the area. So all those things I talked about earlier in terms of air pollution, in terms of injuries and the like. Now, this was interesting because, you know, one of the reasons we like our rural areas so much, some people visit them on holiday, and we go on about encouraging staff to come and work with us here because of the beauty of the local area and how wonderful it is. It does look beautiful, even when it's pouring with rain, hugely. But interestingly, people are less likely to walk in those rural areas. So walking is much more likely in this green area here in urban areas, almost, but not quite, almost double, or 50% additional walking happens in urban areas than it does in rural areas. Much less likely to use the bus, much less likely to use rail. So again, using those private vehicles for travel and transport and not getting the net benefit of active travel in those areas of cycling and walking. So I think that's an interesting point, and that's something perhaps to do with the infrastructure around rural areas. Very difficult to walk when you haven't got pavements to walk on. Very difficult to walk where, yeah, perhaps the discontinued areas of pavements between two villages is occurring, or where you're walking along dangerous roads and things like that. So that has an effect on people's ability to maintain their health. And like I said, accessibility to things is important. Accessibility to healthcare, as we've heard already today, is absolutely vital. You don't want to be changing 2 or 3 buses when you've got a dodgy knee and you want to get to the knee clinic, or you want to go and change your batteries on your hearing aid, as Steve mentioned earlier. You know, we don't want to be doing that kind of thing. But in all the statistics of whatever you're accessing, whether it's fun things or things you've got to access, it's much harder to do that in rural areas, and it's much harder to do that in rural areas if you're doing it by non-sustainable manners, like walking, cycling, or using the bus. So by using public transport and walking, you see the huge increase, particularly access to healthcare and hospitals and GPs, so primary and secondary services, takes much longer if you've got to walk there, or if you've got to cycle there, or use public transport to get there. But the same for things like access to jobs, access to services that we need for day-to-day elements. And it's even bad in that case if you're doing it by car as well. So in green areas, so that's the rural areas again, particularly again, healthcare, access to hospital. We know that from rural healthcare here, only 1 hospital in those 3 healthcare areas. You know, almost double the amount of time again to access it by car. And that's not just access for, of course, for people, you know, accessing hospital, going to hospital with an emergency, but it's also people visiting, it's the health care workforce, and all the support operations around that. It just makes it all a lot more harder and a lot more difficult to maintain good health. So if you're getting good outputs from healthcare in rural areas, you're doing very well, because you're at a natural disadvantage right from the start. And it's nicely mapped on this map by Gary Higgs from University of South Wales. I mean, that almost follows exactly the urban conurbation areas in Wales, just how difficult it is to access some of those places. So the darker purple areas are those that find it difficult to access between no services and say sort of 3 or 4 services in those rural areas across those different postcodes within 50 minutes walking area. So huge difficulties in accessing things in the middle of Wales. In terms of some discussion points to bring out from that. So in rural areas, you've got limited access to public transport. In Wales, 13% of people live less than 800 metres walking distance from a rail station where there's at least 1 train per hour. So that's how the Department for Transport identifies whether you've got access to rail or not. But look at the variation of that. That varies from 20% in South East Wales, in those urban areas, to only 1% in mid Wales. And, you know, even within that, some variation to 0 within that. So huge difference. And more people have access to buses. Around 7% of the population live less than 400 metre walk from a bus stop with at least 1 bus per hour, but varies from 81% in urban areas to 25% in mid Wales. And no sign of that improving at the moment. In terms of accessibility to shops, services, jobs, much more difficult. We've seen that get worse over time as well, as what's something we call agglomeration, even happens with hospitals and healthcare providers, although that's perhaps changing a little bit in recent years. So that's the movement of things all together to certain places, because it is useful for the provider to provide all those services at one location. And therefore, you see things like the village shops and the village services and the communities closing down and agglomerating where there's access at the edge of town or city centres and things like that. So that's why it's really important that healthcare providers work with transport planners around those kind of elements when planning services. And like I said, forced car ownership impacts on population. So you have reduced opportunity for those active travel modes, for the things that keep you fit and healthy. Reduced socialization, additional costs, and it becomes a circular effect, and it becomes less viable to operate public transport, and therefore health impacts, risk of health impacts and risk of collisions, air pollution and the things all become worse and circular. And rural areas particularly are in danger of that spiral continuing. Like I said, air and noise pollution, I think people think rural areas are immune from that, but evidence suggests there's real pockets of problems in rural areas for that. Road safety is a particular issue, as I mentioned earlier, because of the particularly 60-mile-an-hour roads, particularly those where you've got villages or towns and transport using those. Isolation and loneliness is an issue, and comparatively fewer opportunities, therefore, for active travel within there. So urban residents, 64% more likely to engage in active travel, to walk or cycle, than rural residents are. And those inequalities, particularly around people who don't work 9-to-5 jobs, particularly those in rural areas without access to cars, using bus services, particularly we've had issues mentioned from females more worried about using transport in their local area, particularly buses, and older people using buses where there are buses provided and things like that, making it more difficult. And surrounding all of this is something that we can change if we work closely together on these kind of things. So governance issues, lots of them are very urban focused. So even we've had this excellent solution to try and reduce injuries and collisions and increase active travel in bringing in the default 20-mile-an-hour speed limit in Wales. But that's going to have more effect in urban areas where there are more roads that can become 20 mile an hour than perhaps those through roads in rural areas, which won't necessarily be reduced to 20 miles an hour, and therefore you won't see the benefits from that. Even solutions about sustainability, increasing electric vehicles and things like that. Distance and access to charging points are a huge issue in rural areas. There's more charging points in London alone than there is in the rest of the country as a whole. And again, even from that, most of the charging points you find are in urban areas, with some change in that in rural areas over the last few years. So there's this feeling, at least, that governance and people making the wider, big strategic issues happen outside of these rural areas, happen in the urban areas. We hear it all the time in Wales about the urban pull and the urban governance that happens from Cardiff, being very Cardiff centric in how we do these kind of things, and rural being lost in all of that. And therefore also, you've got issues in rural areas of the economies of scale of things, that it's very difficult to run a service in the same manner as it would be in an urban area because of the penalty of distance. So in social care, somebody seeing the same number of clients in a rural area takes 4 or 5 times as long as it does in an urban area. So there's a difference in costs to the workforce on that kind of thing. Very difficult to work that out if you're using the same cost mechanisms. But let's finish on some more positive notes. We've heard a little bit this morning about the potential for telehealth, the potential for healthcare at a distance to reduce some of that mileage happening. And that is good if we, and I think Steve said this really well as well, if we find the sweet spot between the human touch of those services and the annoying transportation difficulty elements that we could get rid of. And it is finding that balance at the end of the day. And I still don't know if we've always got that right in some of the projects that we've done on that. But the solutions, like I said, are very often urban centric. So we need to start thinking more about how we bring together the communities in developing these solutions at the end of the day. So bringing together the people working in partnerships in communities is absolutely vital for doing this. I always think when I've worked in rural areas have what we call in the business high social capital. So they work together well, they look after one another well, they're quite innovative and creative in terms of coming up with their own solutions. We need to be able to support that in terms of legislation and governance and offer a mechanism for bringing that out and making that work really well. We were talking on the table over there earlier on, I've come across some great local solutions where people have wanted to set up their own minibus scheme, set up their own access to healthcare via local taxis, even offering money to put into these things, but too often finding it difficult to see it through because of legislation or difficulty in terms of costs and finding the resources to do that. So we need that to change moving forwards. So we need more public engagement, more community-led projects, meaningful changes that would offer the most impact for communities, coming from communities themselves and being supported by legislation where possible. So making the most of those dial-a-ride service, making the most of car shares and on-demand buses and things like that. And you know, I work with the Welsh Government on this. I was talking to Lee Waters, the Deputy Climate Change Minister, yesterday about trying to improve the rural bus services and how we join those together better. And he is very serious about making meaningful change in those rural areas. But as we remarked, we've got to bring together all the actors and the right players in order to do that. And health providers are absolutely crucial to being at the table in making sure those decisions happen really well. So yeah, there's just got to be better joined up thinking within all of that. And in order for that to happen, I need you all to get signed up to our project. So get involved. There will be opportunities to spend some of the money that I've got from the project on local community schemes, as long as there's a bit of research involved in them, how we improve that. So looking at some of the pilot schemes that might improve access to healthcare could be something that we've got a little bit of money for. When I say a little bit, it's a real little bit, between £2,000 and £6,000 for projects, but something that might just help springboard a project forward or do a bit of research around an already established project. So do get involved and sign yourselves up to the network, and we can start bringing these things together and making access to healthcare and the implications and outputs of transport and mobility on healthcare improved, particularly with an emphasis perhaps on rural areas in Wales. Thank you very much.
Thank you, Charles. Not often do we have a speaker who offers solutions and money. Do we have any questions from the floor for Charles? Can we get the microphone to Tom?
Thanks, Charles. As you know, this may not represent the community hospitals association. And one of the places that the elderly people in particular often find it difficult to access are the community hospitals. And if I take one example, which has been posted many times, but we get lots of messages of sympathy, no one's taking responsibility. If I take perhaps Ysbyty Allwen in Porthmadog, a new hospital on the top of quite a steep sort of hill, loads of buses go 1/4 of a mile away down here. Only about 4 or 5 a day actually go up to the hospital, and that's generally when the staff are changing their shifts, etc. Now, when I go to community hospitals in England, I would often find there are buttons there for people who go to those hospitals to press to alert the fact that they want a bus, and the bus therefore makes that short diversion up the hill to pick them up. Lots of buses could do that as far as Allwen is concerned, and I could mention other hospitals in North Wales as well in a very similar situation. But it's very unclear to me as to how we actually get someone who takes a responsibility. It's quite damaging for elderly people. It's about £5 plus each way for the people in my area to go to the hospital and back. And when we had the COVID vaccination there, it was a bonanza for the taxi companies. So any suggestions you have as to how we turn sympathy into delivery, would be very grateful for.
But I think that's yeah.
I don't think that. I believe the people online are struggling to hear the questions from the floor.
Oh,
so
okay.
can you summarise the question? And
so the question was about how we improve some solutions, or how we make more of the solutions to bringing access to healthcare. Well, how we make them work, I suppose, at the end of the day, and how, you know, there's some good examples where you were saying in England where you can call a bus by pressing a button to come, and it will come off its route to come and pick people up at the relevant point. So on-demand flexi kind of bus system, and how that doesn't happen perhaps in some hospitals Yeah, and not just, you know, general hospitals, but community hospitals as well in Wales, and GP surgeries and things like that. And I've thought, really, at the end of the day, what we really need to do, you know, we hear a lot of these kind of stories. We need to put them together and put them to the government at the end of the day. You know, and lots of transport has often been around quantitative data, lots of statistics, lots of figures. It's really easy to lose the person when you're looking at these kind of statistics and figures and using modelling to do that. And of course, that's an important element, and it can help with costs and finance, but you lose the nuance, so you lose the stories within all of that. So what I'd like to do in the Think project is invite people to send me those kind of stories and to put them together and make a narrative, if you like, around these kind of examples, so that we can then, you know, lobby for better services at the end of the day. And I think that's really where the issues have been. And because they're often quite individualized, although they build up into, you know, big stories at the end of the day, they get lost, and people don't always want to complain about their healthcare. Perhaps some people in here accepted. You know, they're just grateful to have been looked after at all, and I get that. And I understand that. And we get that bit with community transport as well. So people are often very grateful to have a community transport provider be able to take them out once a week to dinner, or take them to the hospital for their appointments. But the service actually isn't very good and isn't very high quality and takes a long time, or is very uncomfortable. And really, we need to collect those kind of real life stories as well. We shouldn't be accepting that poor level of quality at the end of the day. We need to find. So I think the stories could help back up the statistics that we have in order to make a difference for people. So that's what I'd like to offer, is send me your stories and examples of where it's worked really well and where it works really badly in terms of access to health.
Great, thank you, Charles. Yeah.
I was, well, sort of in 5 minutes, my area, which is looking at care of people with serious mental illness, particularly mainly touching on transport issues and that. I wonder what research there is in looking at both the physical barriers and psychological barriers to transport for people with serious mental illness. I have many patients who get translocated out of urban areas into rural communities for social housing. They're often miles away from transport. For them to access a GP surgery, there's no hospital transport available for that. And yet many of them may have a psychotic illness where they're fearful or paranoid about going into the community. Is there much research being done on that? If there isn't, could we have a chat?
Yeah, there definitely needs to be more research on that. You're absolutely right that, again, repeating the question. So people with mental health difficulties, and you mentioned really, you know, severe mental health difficulties, if they're accessing healthcare in one way or another, it's really difficult to do that via public transport because they're very anxious about the bus. It might trigger, you know, a mental health issue, or just it's a total barrier altogether and people can't do it. And we get that with some people with mild mental health issues as well, who, you know, would be benefit from being looked after in the community, but can't access the places they need to, or access other people for support and things like that. So yeah, there's a little bit of research on that, transport inequalities, a little bit about transport justice and the people who get excluded from using transport. But there definitely needs to be some more. So yeah, I'd be happy to talk more about supporting something in that. Would be good.
Thanks, Charles. I'm going to have to wind it up now. I'll be in terrible trouble for running late.
Thank you very much.
Thank you so much, Charles. As you saw, Charles has made a kind offer for all of you to get involved with this project, so please take him up on that offer. And I'm sure Anna can link people together if they haven't got the links, but they're available on the slides. Thank you very much. We're now going to the first breakout session, so if you can choose which breakout you wish to go to. There will be a slight pause of about 5 minutes for a comfort break, and also to try and make the technology work with France in this room. But sorry. Yeah, as far as the rooms go, over for those doing it physically, room 1 is downstairs in the International Pavilion, room 2 is upstairs, and the International Pavilion is just there to the left of the Shepherd. So see you over there in 5 minutes. It's lunch after that, so don't dally coming back.
Yeah. Good afternoon, everyone. Thanks very much for coming to this session. My name is Colin Callow. I'm Head of International Programmes at the Innovation Agency. We're an academic health science network. The innovation arm of the NHS in England. We're one of 15 health innovation networks in England. I'm not Philippe. I'm going to introduce you to our star actor in a moment, but I just wanted to give you some context about the presentation that you're going to hear and also a live demonstration connecting us with, is it Paris or South? The Loire Valley in the centre of France. So hopefully if the technology works, that's all going to be great. Just to give you a bit of an introduction, so I'm Head of International Programmes at the Innovation Agency. Part of my job and my team's job is to horizon scan for promising innovations from around the globe, innovations that can address some of the major challenges that the NHS is facing today. And we support implementation, real-world evaluation and adoption of these innovations right across the United Kingdom. The innovation that you're going to hear about today was introduced to us through our partnership with the European Institute for Innovation and Technology, which we're very privileged to be part of. And these are innovations that have been backed by the European Commission. This particular innovation that you're going to hear about comes from France, originally developed with the support of the European Space Agency. It's designed to improve access to diagnostic ultrasound services in rural communities. So really trying to achieve that objective of providing equitable and improved access to diagnostic ultrasound services. So I'm just the warm-up act. So I'm going to introduce you to Philippe Homsey, who's Export Director at Adecotech, and he's going to introduce the technology and then hopefully give you a live demonstration if the technology works, connecting us from here to the Loire Valley in the centre of France. Over to you, Philippe.
Thank you very much, Colin, for this introduction. I would like to thank everybody for attending this session, and I would like to thank Anna and Jack for inviting me to come over and take part of this conference. This is my first experience to Wales. Never been to Wales before. To the UK, yes, many times, England and Scotland. And I'll tell you the story why to Scotland, because of the technology. So what I would like to do is to put the maximum focus on the live demonstration that we are going to perform in real time with the patient laying down in France, right? Because we have Anna has allocated 30 minutes for the whole session, so I would rather keep the majority of the time on the live demonstration. But I'm very much happy if there is any interest later on in the future to come back to Wales and provide in a wider way this kind of live demonstration and go through more details. But you are very much happy to pick up one of these brochures that I've got on my table if you want to know and learn more about the innovation. Anna, I'm happy to start with a very quick presentation just to set up the scene.
But it's a real patient. So Bob was one of my patients, different area of the country.
Okay. So I'll take you through a very quick presentation just to let you know who we are, what it's all about, the technology. So Adecotech is the name of our company. It's a France-based company founded by a medical doctor sonographer, Dr. Eric Lefebvre. He is a key opinion leader of ultrasonography in France. The company is specialized in robotic ultrasonography. We only do imaging based on ultrasonography. The next one, please. Sorry. So Melody is the technology that I'm going to present today. Melody is a very strong and high and very powerful telemedicine tool, able to provide diagnostic processes to remote communities that need ultrasonography. The Melody technology was invented in the context of space medicine. In the early 2000s, the National Center for Space Study and the European Space Agency just put their head together to work on a prototype, and that's how the Melody history started. So it started in space, and now Melody is applied to Earth. Following one. Everywhere, not only in Paris, yes, do I pronounce it properly? Paris. Everywhere, including France and the most developed country, the US, Canada, Western Europe, there is a medical desert. In other words, the biggest challenge is the lack of medical resources, especially in rural area. We do have in France, small city, you need to travel at least 60, 70 kilometers to reach the first hospital, you know. So this is the biggest challenge, one, because of the geography. Somebody mentioned this morning that Paris is a big territory and small population. I wonder what would be the population, 130,000, 135,000 in Paris anyway. But all these people need to travel all the way down to reach the first hospital and to get the care service. But also a lot of small medical centers or small hospitals, they lack of expertise, especially in diagnostic, ultrasound imaging procedures, the one that Melody is addressing. Next one, please. So how it works, and we will see it later on. The Melody solution is made of two sides. On the left-hand side is the expert side. It could be a hospital in Cardiff, as an example. And the patient side, it could be around the corner here, where there is no sonographer, there is no radiologist to perform this procedure. So we need a connection, an internet connection with just decent bandwidth of 2.5 megabit per second, which is not a big deal, yeah, in order to link the two sides. From the expert side, the expert sonographer in his hand, he's holding a dummy. He will be rotating this dummy, and at the same time, at the patient side, you've got the real probe, which will be replicating exactly the same movement of the dummy probe. So in front of the expert, there are two screens. On the left-hand side is the video conferencing system, which allow the communication, direct communication with the patient and the medical assistant. And on the right-hand side is a mirror of the ultrasound machine, which is located at the patient side. Not only the expert sonographer can control the real probe from distance, but also on his PC panel, touchscreen PC panel, he can do all the adjustment and the changes of the setting of the ultrasound machine, which is at the patient side. So the expert controls two things, the real probe of the ultrasonography and the ultrasound machine itself, which are on the patient side. Next, Anna, please. So the system has been validated. We do not need to validate anymore the system because over 25 systems in France, Western Europe, North America have been deployed. Of course, we've got all the certification to be put on the market, CE mark, the FDA for the US, Health Canada, and the quality management system of the company complies with ISO 13485. Next, please. The Melody system can do almost all type of ultrasound procedure except endocavity. Melody does not do endocavity procedure. So everything external from obstetric, prenatal, radiology, pelvic, urology, etc., Melody can do this. Many are the benefits brought by the system, but I would like to highlight three main benefits. The first one is improve access to quality healthcare services, and in this case, access to diagnostic ultrasound imaging. The second one, and I heard it a lot since the beginning of this session, save travel time and transportation cost. And the third one, since the breakout of the COVID pandemics, Melody started to play an additional barrier to stop the spread of the viruses between the physicians and the patient, but also to avoid the patients going down the road to a hospital where, by definition, it's a high-risk environment of viruses and this kind of, diseases, right? And okay, these are all the clinical studies published already in France, Canada, North America, about the Melody system, using the Melody system in a variety of intended use. The last one. We are today a team of 6 people. On the left-hand side, Dr. Eric Lefebvre, he is not involved in the day-to-day business, but he is bringing us the credibility, the background, the medical background, and all the rest of us, they are robotic engineers, software engineers, test validating engineers. Myself, I do develop the system outside France, so everywhere but France. So I'm very happy that, and now the following slides, you'll see, I'm very happy to tell you that with the help of the innovation agency, Colin, end of last year, we deployed the first system in the UK. And here, the story with Scotland in Inverness, where we deployed Melody in Inverness. And in a couple of months' time, the robotic arm will be traveling a bit further north to places like Wick, Golspie, in order to start scanning all these patients who are reluctant to drive 2.5 hours to go down to Regmore Hospital in Inverness. So this is about the presentation. Let me suggest that we go straight to the management session. We will put the camera on the screen, yes, like this. Right, okay, but for the camera now, because I'm not sure whether we can see. Yeah. So what I'm going to do, I'm going to connect with France. I've got here my mobile version of Melody. This is the dummy probe I was talking about. This is mirroring the ultrasound screen machine, which is in France. So I can get control on the setting of the ultrasound machine from Paris with the ultrasound machine, which is in the wire. And here, as you can see, this is the video conferencing system where I can see the room where I'm going in real time planning the patient who will be laid down in France. So, is there any sonographer or medical doctor in this room? Don't worry, I'm not Dr. Nader, but I will, in a couple of minutes' time, if you don't mind, I will invite you to examine the patient, right? No worries. It doesn't hurt, it's like a Game Boy.
So you just stand in front of the screen.
Yeah, we need to. Probably speak.
Well, just watch out because there's a high-class things going on here.
Probably they can see on the screen.
Right.
I can see this. Charlie, bonjour. Tu nous entends bien? OK. Très bien. Je suis connecté aussi bien à la vidéo qu'avec le MEV. Alors, j'ai appuyé. Ça y est, je suis connecté au robot. Voilà, je prends la main. Probably on this.
Say in English what you're doing.
Sorry. Okay. So now I'm trying to connect with France. I've got two screens in front of me, one for the video conferencing system, so I can talk with my patient and the medical assistant who will be holding the frame of the robot, and the other one is the mirror of the ultrasound machine, which I will be able to see the ultrasound images in real time on this screen that you can see here, right? And because if it is a touchscreen ultrasound machine, I'm able with my fingers to do all the setting changes of the ultrasound machine from this PC panel. In other words, switching from one mode to another, to a Doppler mode, to a column mode, take the measurements of all the organs, the kidney, the heart, etc., etc. But at the same time, through the other screen, the video conferencing system, I will guide my medical assistant, because the medical assistant will be following my instructions in terms of positioning the robot. In other words, all the gross movements are made by the medical assistant. Once the spot has been identified, as from this moment on, with the dummy probe, I will be able to examine this volume of the belly that I want to explore. So now I'm going to ask Charlie to play the role of the patient. So I don't know whether you can see Charlie here. Let me. This is Charlie, and Afaf, the medical assistant, standing by the patient. Okay, so they hear me and I hear them. So I would start asking Afaf, who is the medical assistant, Afaf, I would like to explore the liver. Would you please position the robot on the epigastric position? And we've got a medical doctor here in the room, and he will be examining Charlie's liver in real time. Take my seat.
I'll just say underneath this.
All right. Okay.
It's a bit sadder.
So this is the dummy probe. You cannot do this translation, but you can tilt it and rotate it as you like. And this is the screen of the ultrasound machine.
Très bien.
Qu'est-ce que tu dis? La synchronisation.
So you can
only tilt it and rotate it. If you want to go further to the left, you need to ask the medical assistant to drag the frame of the robot to the left in order to. Now, you can control the setting of the machine. For instance, you can play with the depth here.
Yeah.
Voila. And the gain here.
Yeah.
Just voila. Okay. You can switch from one mode to another. The color, for instance. Okay. Push the color with. You have understood everything. Okay.
It's very easy to use.
Well, you can do a Doppler PW. If you push on PW with your finger, you position the cursor here on the vein. On the vein. Okay. And push again PW. And you've got the Doppler.
Oh, yeah.
Right? Now, back to B mode. Here we go. Now, if you want to freeze the image, you push in here. Voilà. The image was frozen. Now, once the image was frozen, for instance, you can take the measurements of the organ, push on measure. Okay. Drag the circle at the initial point, click, and drag it again to the extremity, click, and you've got the length of the organ, 1.08. Yeah. Okay. So you unfreeze and you go back to the B mode. There we go. So you can rotate it. So you see, it's very easy.
That's amazing, yeah.
Although you are not a sonographer,
No.
but you can imagine for sonographers or radiologists who are used to doing ultrasonography, manual or conventional ultrasonography, it takes them probably 3 or 4 examinations to get used to it.
Yeah.
It's exactly like switching from a manual gear car to an automatic car, you see? So this is how you can control, provide, examine a patient in real time from a distance. Yeah.
Yeah, it's very easy to use.
Yeah. Anybody else like to try? Doesn't hurt. Come on. Doesn't hurt. Please come along. What's your name?
David.
David, thank you very much, David.
Thank you very much.
You are a medical student. What's your name?
Katerina.
Katerina, go ahead. This is a dummy probe. So you can explore the belly of Charlie's. The Loire Valley is approximately 611 miles from Paris. Right? Just to let you know. So I did this kind of examinations from Vancouver, which is over 80,000 kilometers from Paris, right? So distance is not an issue as long as technology works. We need the coverage of at least 2.5 megabits per second as a bandwidth. The rest of it is easy. It's just boiling.
Can you explain to me how? So can you explain this?
Yeah. So
Gel thing.
with the gel, yeah. Normally you ask the medical assistant to put the gel and position the frame of the robot on the epigastric, because here we are exploring at the moment the liver, right? So the gross movement will be done by the medical assistant, and the refined movement, the volume that you want to explore, is done by your hands. You are the experts, right? So you can tilt it, rotate it around one point. And of course, you can switch from one mode to another, as I explained to David. Yeah?
So
No, this is a unique.
Yeah.
This is a unique. This is an innovation. This is why.
So it's not put in use?
It is. It is. Yeah, in France, but also in the UK now, in Scotland. Yes.
I didn't see any of that there.
There is one in the southeast of the Parisian suburb called Créteil Hospital, which is on the other side of Paris. But we've got over 25 Melody systems deployed in France and abroad, and one in the UK.
Perfect.
Yes.
Thank you very much.
Welcome.
So I leave it here?
Yes. So can I release my colleagues?
Sorry?
Can I release my colleagues? Okay. So, any questions before I release my colleagues? Anyway, what I'm going to do, I'm going to leave this if somebody wants to try it without patient. Sorry? I'm done here. Yes, I asked him. Any questions? Any questions? There are plenty of questions. Everybody asks me a lot of questions every time I present this technology. I'm sure that in the afternoon there will come these questions, because this is something unique. This is something new, and people need some time to get used to it. Okay, in which case I will release my friends. Thank you very much for your attention. And please, I'm here till the end of the day. Should you have any questions, come back to me. And I have some brochures if you want to learn more about the technology. Thank you very much.
I'm just going to close and say thank you to Philippe and Colin for that demonstration. It was probably a bit awkward if to those who were online to follow, but there was a robotic display there and they were getting delegates to see how the equipment worked and linking with the Loire Valley in France. So now it's lunch break. So to those online, if you rejoin us at 1:30, and to everybody in the room, if you use this opportunity to go around and view the posters, have lunch and just generally mingle, and we'll see you all back here at 1:30. Thank you. Yeah.
Seats. Sorry. Right, yeah. Are we ready to go, Anna? Okay, Prananda, good afternoon, everyone. Thank you for getting back in such a timely way. I hope you've all had a chance to see the posters. And just a reminder to vote on them, and those online will get a chance to vote later in the week. So we had such a large volume of high quality requests that we once again have gone for our bite-sized session. This will concentrate on digital solutions, and our first speaker is Tom. So I'll invite Tom to come up now and speak about AI. Thanks, Tom.
Thank you, Jack, and Prananda Pawb. Good afternoon to everyone. This slide, yes, the original slide we can. This bite-sized session is about transformation, and it's about transformation using technologies. And I'm going to start with a very short introduction on one of those technologies, AI, etc. And then we will be having 3 presentations from people who are immersing themselves in it, and we learn about their experiences in doing so. It was about 6 months ago that one of my former colleagues in the USA, I worked for an American company for many years, sent me a little email which said, in our village in remote rural Arizona, today I went to the primary care center, the surgery, and I was greeted with the words, "Great news, our new doctor is a robot." Now, it's not quite like this slide actually sort of projects. What that practice has done is to adopt a number of technology applications which are using sort of AI, and they have developed a strategy for deploying them. And one of the issues, I believe, with AI as far as rural Wales is concerned is that few people have got any strategies for the deployment of the technologies. Lots of people doing very useful things in deploying them, but nothing much in the way of a strategy to deliver the overall benefit that we could actually get from it. The applications in that town in Arizona come from a university in California. And there they study, of course, all the traditional things, but they also have a number of technology courses. And it may well be that our students from Cardiff, etc., also have similar sort of technology courses as well. But what I want to stress is that the issue is not one which is purely across the Atlantic. In England, they have produced 2 excellent sort of booklets on AI, and if you haven't downloaded them and read them, then I commend you to actually sort of do so, because you can see the future of of many medicine applications today. Now, in this very short period of time, I can only look at AI in a few value sort of areas, and there are 5 areas that I see being adopted in strategies by people in other countries: interpreting medical images, patient safety enhancement, robotic-assisted surgery, enhancing staff training, and virtual care. And of course, there are other sort of areas as well. So very rapidly, if we deal with medical imaging, one of the issues as far as Wales is concerned is that we still have some disappointing figures on stillbirths. And in Cwmtath Morgannwg, they are addressing that particular sort of topic. We have, it's not moving on for some reason. There we are. We've had an excellent presentation this morning on ultrasound, and it of course is something which, in my view, any community hospital should now be able to provide sort of services with. And many of those systems, and I will have words with our colleagues later about the one which we have, Melody, have auto-generation of reports using sort of the cloud there. There are many other applications which one can look at in that particular area, but in course of time, move on to patient safety. Great Ormond Street and Stoke Mandeville have produced an excellent AI sort of system for ophthalmic surgery, which gives a lot of guidance in terms of improving the outcomes of the surgery and also the recovery sort of period. They have a post-op review. You do not get a post-op review with either of these hospitals and ophthalmics with a consultant, a doctor or a nurse, only with a robot, because that's the way in which the robot actually is self-learning to improve itself for the next time round. Another system in patient safety is the improvement in pathology diagnosis for prostate cancer. That's live in at least 6 hospitals in England and under test in Cynhadledd. Virtual care is another area in which AI is playing an important sort of role. Care closer to home and improved surveillance. Of course, all over the UK, virtual wards were set up in order to deal with COVID per se. And the published papers show that indeed those virtual wards can be proven to have reduced hospital admissions. They can also be proven to show that they saved nursing hours. What I haven't yet seen is any report on patient outcomes. And at the end of the day, the important thing for the patient is the outcomes. And I think the jury is still out on whether the outcomes for the patient are as good under virtual care as what they are with care inside the hospital. The big example as far as virtual care concerns, of course, the Mercy Virtual Hospital in St. Louis has no beds of its own, but looks after more than 1,000 sort of patients. Everybody gets a standard home pack and special packs. One of the big areas which they deal with is cardiology, and we'll be having a presentation from Vicky on cardiology a little later on there. In order to deal with such volumes, they have an AI monitoring system. And only, of course, the exceptions need to be directed through to the clinicians at the stations per se. One of the other things that they deal with is self-management of Parkinson's disease. And I was delighted to see just in the last fortnight that NICE has now approved 5 systems for doing the self-management of Parkinson's disease, some of which have got cloud AI backup to them. Robotic-assisted surgery provides improved outcomes and earlier home discharge to rural areas. We do have in Wales a national robotic-assisted surgery programme. I have a personal criticism. It's far too inadequately funded, and its plans are over far too long a timescale per se. The great success across Europe has been the Da Vinci surgical robot. There are dozens of strong examples of how successful it's been. We have one now up in Ysbyty Gwynedd, and we are longing for it to be put into use 24 hours a day, 7 days a week, in order to improve the patient outcomes. Let me then turn to staff training. Learning in the metaverse, that halfway house between virtual reality and the real reality. England has got excellent program on blended learning, and well worth looking into what they're actually sort of doing there. And it's necessary if we are to address the staff shortages. It's unrealistic, I believe, and I did work in the Department of Health doing various planning jobs. It's unrealistic to believe that the normal recruitment and training process is going to solve the demands that we have sort of for our staff. We have to move towards more technology solutions. I understand that Cardiff University is using virtual reality, and you certainly on the website, you can look at various virtual reality tours there sort of with them. Up in Bangor University, virtual reality has been used for the training of radiographers. In Velindre, it's been trained for the training of nurses. And of course, virtual reality is being used in a blended learning way right across Europe and the world. The big selling point in terms of the metaverse is certainly the separation of these 2 boys in Rio de Janeiro. The experts in Great Ormond Street had screens, various screening processes carried out on the boys in order to build an AI model of those 2 little boys. 27 times the combined teams went through the operation in the metaverse, each time finding out what the problems were, each time asking for some more scans to be sort of carried out to build up the model. And eventually, the 9 real operations came. And if everyone wants to see the value of AI, that's the picture which shows it. So, my question is, where is the strategy for AI in healthcare in rural Wales? Now, I don't know whether Chris is still with us. He was here this morning and from Betsy Cynhadledd there. That's one of 9 organisations that I can identify which has responsibility for strategies as far as some aspects of rural Wales is concerned. But I can't identify any of them working on a strategy for AI for rural Wales. Although I hope that one or more of them actually sort of are. Well, what should it contain? Well, in my view, there should be timely access to medical imaging systems in local community hospitals right across our region. There should be a blended learning strategy for our rural hospitals so we can rapidly be increasing the numbers of staff that we have there. There should be better patient safety performance which would be measured by fewer readmissions from the rural areas. Virtual care can be improved in many, many areas, and we'll hear some again in a few minutes' time. And we can have even better outcomes in places like Brongais if we are using AI with robotics. Scaling innovation requires a clear strategy and implementation plan. Lots of good ideas come from individuals, from people. The replication of them to make a real impact comes from structures in organisations. And that, in my view, is what we are currently missing in rural Wales. So the future, I believe, is based around AI and a few other technologies to give us a transformation of the effectiveness of our rural healthcare.
I'm sure you have questions for Tom, but I think as we've got bite-size presentation, we're going to whistle through this, Tom. So grab him over a cup of coffee or send questions in line and we'll refer them on to Tom. Thank you for that. Thank you for that whistle-stop tour of what AI can do for us. We're now